Okay, we have a CEREC guide case here. It looks like we've had a tooth number uh, 12 removed, and we're ready to plan a CEREC guide. So the first thing I always start with is always the obvious, and that is when I'm looking at tooth number 12, that's a premolar. So I always want to start with my ideal, which in this case would be a 4.3 by 13 millimeter implant. So now, again, the bone and or the approximate adjacent teeth may dictate that we don't use this implant, but I will always start with my ideal. Now, this case has been sent to me, and the CEREC Guide X-Ray 8 has already been registered, and looks like the registration is very accurate. I think the bigger question in this particular case is setting the D2 value more so than the implant planning. But what I would like to do before we move forward is go ahead and kind of give you an idea of how I'll do this. So what I'm going to do is I'm going to turn everything off for the time being so that all we see is just the implant and the natural teeth and everything. It's the natural teeth and the bone there. In fact, I'll actually go ahead and turn the implant off as well. So now when I'm looking at a case like this, what I'm looking at mentally, again, in the beginning, everybody's going to do this a little bit differently, but in the beginning, mentally, this is kind of what I'm looking at. So if you don't mind, what I would like to do is draw out for you what I'm looking at here. Okay, so if we take a peek here, I'm going to start a whiteboard here, and the first thing I do is I kind of outline what I'm seeing here. So what I see right here is the palatal tissue. The tissue goes something like that. Okay, and then what I like to do is go ahead and highlight the bone as well. And what I see here is the bone is somewhere like that. Okay, so now this gives me a visual of what I'm looking at. So now I have a better idea of the bone level and so forth. And the other thing we can also even take a look at here is we can kind of see where the tooth socket was, just like so. And this is important sometimes based on, depending on when the tooth was taken out, and if it was grafted, we know that we're going to have the most dense bone there based on the graft material we may have used, or if the tooth was just taken out 6 to 8 weeks ago and we're doing a delayed immediate placement, that will be not so stable bone, so because it hasn't fully filled in yet. So, and these are important things to kind of take a look at as we're planning along here. So I like to always begin by understanding kind of what it is I'm looking at, what I'm seeing. So hopefully that is helpful as we move forward in the planning process. So what I would like to go ahead and do is I'm going to get rid of that, and I'd like to go ahead and bring all the data back up. So here we have our implant, okay, and let's go ahead and bring, just start with the implant itself actually. And actually, let's go ahead and bring the CEREC data back up as well. And there's our CEREC restoration. I don't really care to see the adjacent stuff. So the first thing I'm going to look at in this case is my bone level. So we can see our bone level is somewhere right here. So I think initially our implant placement itself needs to be a little subgingival. It needs to be moved a little bit more apically. In fact, if you remember, a general rule of thumb would be based on the gingival margin, we want to be 3 to 4 millimeters apical to that. So if we use this line as our gingival margin and we draw, let's just call it 3.5 in this particular case. If we draw 3.5 millimeters, we want our implant plan to actually be somewhere about right there. Okay, so that's where I'm going to want my implant plan. Now, what I do want to take a moment to discuss here, and let me move the implant out of the way, is our CEREC design here. Now, I'm not saying that our CEREC design is incorrect. I'm just saying that I do have some questions about it. And the reason I have some question about it, let me bring my whiteboard back up here. And here again you can see our initial drawing. So let me go ahead and erase all of that. There we go. So that is all gone now. The reason I'm worried about our CEREC drawing here is I see one cusp tip right here and one cusp tip right there. This just doesn't seem right to me. Again, I don't have the benefit of having seen the patient clinically. I don't have the benefit of seeing the CEREC data. It just seems very unlikely the palatal cusp would be so low and the buccal cusp would be so long. I would question whether or not this patient is going to be moving and hitting that buccal cusp in excursive movements, if this is giving me an ideal picture of what's going on. Now again, it's overkill. I get it, it's overkill. But the other thing that this brings into play is our central groove seems to be right here, correct? Now, this tooth looks like it may be angled that way, and I may have a tendency to plan it incorrectly. So again, I prefer to take a little extra time and make sure that my CEREC drawing is correct, okay? Let's go ahead and get back now to the implant planning stage of this. So I'd like to see our implant plan to be somewhere probably at this level right here from a planning perspective. And again, if we take a look, it's going to look deep interproximally because the interproximal bone does go up. And then we can go through our planning checklist and go mesiodistal, buccolingual, all those things. But that's not what the main question is here. And I think you guys are probably right that this is probably going to unfortunately need a 3.5 millimeter implant to be able to allow us the space in between the teeth. Now, again, you know my feelings. I would personally change this to a Nobel active implant simply because I would get more aggressive threads. I would condense and expand the bone site, and it's been a very good implant for me. It's a conical connection, just built-in platform shift, just many different good things here that I prefer to work with. So now let's go back and focus on what it is that we talked about. So let's focus on the CEREC guide part. Okay, so now the question is how do we set the D2 value on this? So one thing I want to point out here is the angulation of the X-ray aid. Again, it is nicely placed. If we take a look at it again right here, you can see that. We take a look at it in this window, you can see that it's pretty level with the occlusal plane, well placed. Placed to the buccal. In my preference on upper teeth is try to place it to the palate, simply because the cheek won't be in the way and things like that. But again, we're good, okay? But I think the one area that we could improve on in this is right here. I think that we have allowed this X-ray aid to be tilted this way. And this is going to become a little bit of an issue for us moving forward. And the reason for that is going to be this, because to mill this out properly, we need to have our D2 value set roughly at least this high. So when we have one side lower than the other, that means we have to extend the D2 value all the way to at least be this level. And since our implant is going up and down this manner, the D2 value is going to have to be at least that high at that parallel level versus the X-ray aid being tilted. Now again, the software will re-tilt when it mills, but again, the D2 value has to be at least that high. And I hope that didn't come across as totally confusing there. And again, these are things that are, honestly, they're difficult and it just takes a little bit of time. So let's focus on setting our D2 value here. Again, we'll go to the sleeve tab. And right here, we can set our D2 value. Right now, it's at a 12.5, which is essentially the 13 millimeter implant. And as we talked about, if we're going to use the standard drills, a 13 millimeter implant, we want a D2 value of either 23 or 24. So let's set it at 23 and kind of see where we are. And now what we can see here is this orange line right here represents the D2, where the sleeve or where the top of the surgical guide will be. And the issue we're having right here is this part of it. While this side is more than high enough above where we need it to mill, this side is not. We need to get it up in this area right here. So to get it, this part right here up in this area, let me zoom in a little bit here so we can show you a little bit better what it is I'm talking about. If we want to get, and let me kind of clean up the screen here a little bit. Let's get rid of the implant. If I get rid of the implant, everything goes away. Okay, well, we'll have to deal with it here. So again, this thing has to be above right here. And as you can see right now, it is not. So to accomplish this, we're now going to have to go up in here and change the D2 value to probably something like 25. And now when we change it to 25, we can see that we're high enough right here, and this will not give us a milling error. So again, in this particular case, because the X-ray aid was placed in a bit crooked, in other words, tilted to the buckle, leaning to the buckle, and it could be that the ridge is that way. In fact, we can look at it and see that the ridge is that way, and it's just one of those things we have to deal with. But I do want us to understand, excuse me, what the cause of that is. So again, on this particular case, we would need to have our D2 set at probably 25 to be able to mill this, and then go from there. So hopefully this was very helpful to everybody, and if you have any questions for me, please let me know. I'm just trying to figure out what the possibilities are here for you guys, and I'm always happy to help. So just let me know. Thank you very much, and have a great day, and continue to send me some cases.